So, for those who might not be familiar with your story, could you share those early inspirations of wanting to become a nurse?
Yes, certainly. The reason that I wanted to become a nurse was that at that time, I was only about 4 or 5. I was living in a children's home in the Midlands. To understand why, I was the outcome of an affair of my parents when they were at Cambridge University. My mother was of Irish Catholic heritage, and my father was Nigerian. Um, my mother dropped out of studying classics when she found out she was pregnant with me, and my father went back to Nigeria. Now, uh, it was such a stigma. We have to remember this was 1947, so um, my mother didn't tell anybody anything about my father. And so, amidst all the shock and horror of my mother being pregnant, because you can imagine, but everybody was supportive, including the Catholic Church. And uh, when my grandparents, my maternal grandparents, came to see me and my mom, the nun of it was a Catholic maternity home, sort of blocked them initially. Because she needed to tell them something. And the way she blurted it out was, to be sure, the baby's a little dark. Because nobody had expected this brown-skinned baby to arrive with an afro, and it was black afro, not the salt and pepper one that I have now. So, we talk about intersectionality. I think my early life really encompassed everything you could throw into the intersectionality bowl. Anyway, so my mother totally rejected any idea that I should be adopted. I have so much to be grateful to my mother, because it must have been very, very hard for her with the stigma of illegitimacy, as it was obviously called then, the stigma of half-caste child, as it was called then. Anyway, it was a lot. But, she visited me in the children's home where I was placed temporarily, but it did last for 9 years. And whilst I was there, I suffered quite a lot from eczema, and I had to go to sick bay to get my dressings changed. It was coal tar paste, which was lovely on the itchy, red, painful arms and behind my knees, and that was fine. But I dreaded it when it came to changing the dressings, because there was only one nun that could change them without causing me pain. So I would peek behind this sick bay door, and I would be looking for the white nun in my little child mind. Now, all the nuns were white, but this particular nun used to wear a white habit rather than the black habit. If I saw her, that was fine, because the other nuns would just tear the bandage off, the gauze would come off, it would be painful, I would be screaming, and it was just awful. But this particular nun, she would use what we would call distraction therapy today, because she would use what I thought were very rude words. You have to remember, I was living in a very religious environment, very, very religious. And she would use words like bottom. And I would just burst out laughing, because I thought this was a swear word, bottom, I really did. And it would always work. Uh, She would always get me. I laugh and I wouldn't feel anything. I would feel no pain whatsoever. Now, I'd had an overdose of religion, so I didn't want to be a nun, but I wanted to be like this nun. And then when I heard she was something called a nurse, I thought, right, that's it. So that's what made me become a nurse, and I've never regretted that decision at all.
Fantastic. So, moving forward a few years, set the scene for us to tell us what it was like working for the NHS as a school nurse assistant in Wolverhampton from, I believe, the age of 16.
That's right, yes, because I lived with my mum and my stepfather. That didn't last long because of physical abuse on his part. This issue of um, the ability of some white families, I can only talk about and obviously it wasn't my mom, but my stepfather couldn't cope with the teasing his mates about having, how do you allow your woman to have this half-caste child in the house? And then I went to live with my grandparents, but then I had to go back to the Midlands at 16. And as we've said, I always wanted to be a nurse, and I got this wonderful job as a school nurse assistant, and I ended up moving from a day job to a residential job, because the stresses at home. Nobody was physically abusing me now, but you know, 16-year-old doesn't forget what had happened to them just 5, 6 years earlier. So a school medical officer of health organised moving me because the stress was making my asthma worse. And it was the best 18 months I could have had before coming down to London to train as a nurse. It was beautiful. So I was in it was called a residential school for delicate children. So these were children who had heart murmurs, epilepsy, all conditions that I don't think there are such schools now, but you know, the school was in the countryside, so I think it was the sort of fresh air, healthy, you know, food, nutritious food, etc. And so it was very, very good for the kids. I know that, and I could see them thrive in that atmosphere. And the families visited very frequently, so they weren't deprived of their, you know, relationships with their family. But for me, it was wonderful. It was like a balming, you know, episode. It sorted myself out before I then came down to London. Yes.
Brilliant. And moving forward again, in 1979, you helped establish in Brent the first nurse-led sickle cell and thalassemia screening and counselling centre. What was the dialogue in the community and nationally like at that point around sickle cell thalassemia? You touched on it earlier, but I just wondered if you could tell us a little bit more about what Britain was like at that time and what the
Well,
dialogue was.
it's interesting because both of these conditions are inherited red blood cell conditions that affect the hemoglobin. Either you don't produce it at all in thalassemia major, or in sickle cell anemia, you're basically producing, if you like, the wrong type, because when the oxygen gets low, the red blood cells change from their donut to a sickle banana shape. There was more awareness, a little bit more awareness of thalassemia than sickle cell. And the reason for that was the work of people like Professor Bernadette Medell, who'd managed also to get an Horizon program on it, a full Horizon program on that, you know, obviously raised awareness in the country. Whereas for sickle cell, I'm talking from my own experience. I was the awareness was so poor amongst health professionals, amongst the at-risk communities, obviously the general community. The media hadn't picked it up in the way that they picked up about thalassemia. And so it was, looking back, it was a very sad time in respect, I think, for sickle. There were avoidable deaths during that era. There really were. And a lot of unnecessary suffering by individuals affected by sickle cell anemia and their families. It wasn't a good period for sickle cell.
And what changed it? I mean, we're 30 years on now. What do you think has changed the landscape around both awareness and consideration of sickle cell and thalassemia?
Well, from a personal point of view, the American situation informed and supported me and gave me the idea that nurses could have a much bigger involvement in the care of families than I had realized. There were obviously, as with anything in this country at that time, there were obviously areas of good practice. There were hardworking hematologists, blood specialists. There were hardworking pediatricians, but it was ad hoc, and certain families would shop around because they were desperate. They lost some of their children already with the condition. They couldn't wait for the NHS to sort of pick up speed on this issue. They talked to their friends. And when the charity started, they would come. The Sickle Cell Society that some of us set up. They were just thirsty for knowledge about how they could help their children. They were scared. The families were very, very scared. And I remember in the early days, I would know of quite a few deaths per year. You know, the number of funerals I went to, it was that. And, you know, you can never forget the distress of having to inform a family that their child has died, their teenager has died, their young adult relative has died. And, you know, I've still got the screams in the hallway as the parents have heard, and they're coming. Oh, it just, you will never forget that, ever forget that. And, you know, sometimes when people would sometimes jump on me, I was being, you know, I would jump back at them, I can tell you, because that was, you know, it was this separation of some influential people in the NHS at the time, a separation. They didn't know any families from these communities. They'd never come across sickle cell anemia. They'd never spoken to a mother who's lost her child with the condition. And I would say that to them. I said, you know, stop telling me off. You know, you tell me, what do you know about this condition? And I would get up on my high horse. You know, there's a certain, now I often say that anger can be very useful. It's the positive energy of anger that can drive you into working with others to get improvements. The negative aspect of anger is if it works against you and your career and other people. And so, you know, don't be afraid of having with others identified a gap in services, working together, you know, get the evidence, pull together a proposal, learn from other people who've addressed the issue. It's very rare that you're the first person to have identified this issue. If that's the case, then you've got to come up with models of your own. But that wasn't the case with sickle cell anemia. As I've said, the Americans, you know, there's often derision about the American healthcare provision. But I can tell you something in respect to how they drove the arguments and the evidence for improved care for sickle cell anemia. That is an incredible model, because it opened my eyes to the fact that you don't have to be narrow-minded and use the sort of traditional routes to get something on the agenda. You actually broaden it out. Of course, what then really brought this to the attention of everybody, this sort of approach, was the HIV/AIDS crisis and the campaigning that went on there, both in the United States and in this country and in Europe. And you know, I followed that campaign very closely because it was very, very similar in some respects to the issues and the methodologies that were utilized, that needed to be utilized for sickle cell. So we can learn from other groups. I think that's really what I'm trying to say. Yes.
Yeah, absolutely. So learning from other groups and learning from other healthcare settings, which is something that we will pick up in the live discussion. The other thing I just wanted to pick up on that you just touched on there, Elizabeth, is the importance of being able to give voice to communities and patient and parent knowledge, where those in power or those designing services may not have a view into those communities or those experiences. I just wondered if you could tell us a little bit more about that.
Yes, this was a very important part of what some of us in the health service were aware was needed. And it was very clear that the families, the patients, knew what they wanted. They did not want the affected individual to be labelled a drug addict, a junkie in the accident and emergency department, because this was a young person, Black, coming in, writhing in pain, demanding the strong analgesics. In the old days, it was pethidine, now it's a diamorphine. And, you know, you can, this is where you see the sort of divisions, the sort of separations of groups. So you see, you know, hardworking health professionals, but who were ignorant or not very aware about sickle cell disease, and some of whom harbored racist, negative, stereotypical assumptions about the Black community. So let's take this young Black guy writhing around in pain who has lived with this illness all his life and has had these continuous experiences of not being believed about the severity of his pain, who knows that if he could only see his specialist, the hematologist or her specialist, you know, or the pediatrician who understands this condition, they know that if they can access those individuals, often, it doesn't always apply, but then they knew that they would be believed and understood, but they knew they had to go through all these barriers to get the care that they needed. And they didn't have long to be arguing. I mean, they knew that they could die from this illness, so they're petrified. They knew that they knew exactly what treatment they wanted. They needed, not wanted, they needed this treatment. And so a lot of significant number would wait for a long time before coming to the accident intervention. They would dread it. So this was where changing the model of care was so important, having direct access. And this is where, you know, some hematologists and some pediatricians, you know, specializing in the condition or with a particular interest, would give their phone numbers to the patients and say, look, call me. And that was sort of in those days, and that was unheard of. And, you know, but because it was those health professionals who also were helpless because they had been trying to change the system and getting nowhere. And those health professionals were delighted when the Sickle Cell Society was created, because this is where the voice, the unheard voices started to now be heard and get louder and louder and louder. And that was a sight to behold. I mean, it gave me great joy, to be quite honest. And, you know, there's a naughty side to me sometimes probably, but I would really silently enjoy when I was watching this ding dong going on with, you know, in the meetings that we would have, and somebody would make sometimes derogatory assumption of those affected by the condition. Whoa, did they regret it? And just sit back, watch the fireworks. We had to have it. We had to have that. And we still need it, unfortunately. Yes.
So you recently wrote your memoir. It was published last year or the year before, Dreams from My Mother. Can you tell us, was it hard to write or was it cathartic writing your journey down?
It was a mixture. It was cathartic. It was obviously quite painful. Some of the areas that I explored, and I had to research and get more information about my time in the children's home. The children's home overall wasn't too negative, but there were some negative aspects. So that sort of came back. The worst period for me was the period I was staying with my mother and stepfather. I think I write. It was the only funeral, you know, when I went to the funeral of my stepfather, the only funeral where I've never shed a tear. I mean, I usually find funerals extremely emotional. So that tells you something. So yes, it was a mixture. But on the other hand, what I did, I love reading, and I love reading. I'm very nosy. I love reading biographies and autobiographies. And sometimes when I'm reading autobiographies in particular, I'm thinking, does everybody think that about you? I don't know. So I wanted it not to be an I, because, you know, we can fall down a sort of trap there, I think. I think we're much better than we are, you know. And so I interviewed about 35 or more people, nearly 40 people from different walks of my life, family, friends, health colleagues. And that was good. And I said to people, you know, warts and all, please, warts and all, stops. Isn't that a nicey thing, you know? And it was very, very interesting, actually quite funny as well. So that was an interesting period, just listening to people answering my questions, and then obviously the writing, putting it together. But I had a very good friend who sort of saw I was struggling a bit and said, would it help if we met up every so often to discuss how you're getting on? Because I originally self-published it, and then the publishers came, and this latest one is a published one. And that was helpful, having somebody, you know, literally metaphorically holding your hand through the process. It was very, very useful. I'm one of those people, when I have the white sheet, nothing on it, you know, when you're beginning a chapter or an article, that's the bit I hate about writing, because I'm a very untidy thinker, and I presume I probably would now use all these bubbles or whatever. But anyway, I would be annoyed because I'd want it more clear, but I had to have it all scrambled up and my thoughts going down. Blah, blah, blah. But then once I started to tidy up those thoughts for each chapter, I thoroughly enjoyed the writing. And gradually, after about the third chapter, I worked out, look, Elizabeth, stop beating yourself up. This is the way you write. And it is going to be untidy at the beginning of each chapter, but you know that it will then flow. And once I worked that out, I didn't beat myself up about the way I was writing. And yeah, I actually started to enjoy it.
Brilliant. Well, it's a fabulous read, and I highly recommend
Oh,
all
thank you.
listeners to also go out and buy it and read it, or find it in the
Thank you.
library. So I just want to bring us finally, Elizabeth, back to the community that you've focused so much of your professional career on. What do you think the challenges and opportunities there are now in 2022 for the sickle cell and thalassemia community?
The opportunities for the sickle and thalassemia communities are much greater. They are more in control of their destiny than they ever were. However, every so often we're brought up short, and again, I will focus on sickle cell anemia because, for example, in 2019, there was the very sad death of Evan Nathan Smith in a North London hospital. So this was before COVID, so we can't blame COVID for this. And this was at a hospital that actually had had a very good reputation for sickle cell care. But those who had led that innovation and had been deeply involved and respected by the affected communities, they had retired, one had died, one had retired. So it shows that if you don't have this continuous leadership on issues, there are areas that have in the textbooks are still held in high esteem, but if you actually go in today, might have fallen down. And so, you know, his death, ringing 999 from his hospital bed to get oxygen, it's, you know, and died. That's the reality for that family, that all that good work that had gone before got lost. And what was one of the big issues was the lack of systematic education for professionals such as nurses, midwives, and that, you see, that's a core. It goes back to me in the 70s, realizing I had not received any education on sickle cell anemia. In 2019, we have the same deficit that caused the death. So, you know, so we can't be complacent. On the positive side, I give this as a wonderful example, the fact that every newborn baby in this country can be screened for sickle cell disease, regardless of ethnic origin. I don't think I would have envisaged it happening as quickly as it did. And so, you know, I love the NHS. I was born a year before the NHS. It's part of my personal life. Has been part of my professional life historically. But we have to recognize that there are obviously positive sides, and I've illustrated them in respect to sickle cell care provision. But there are deficits, and we can never take our eye off the ball because clearly we still see it, and there are still some sad examples. So things are a lot better, but we need organizations like the Sickle Cell Society, and we need all those interested health professionals, and we need not to be scared of families articulating, challenging the NHS. And we have to accept that one of the underlying issues as well is racism. We can't step aside from that. And that racism is always going to be there, but it's how the NHS addresses racism is the issue.
Elizabeth, thank you so much for your time. It's been absolutely a wonderful opportunity talking to you. Thank you.
Thank you. Thank you very much.